A very good evening, everyone. We'll start the session in a couple of minutes. Okay, so could we start with the session, sir?
Sure. We'll start. No issue.
Okay, sir. Thank you. So, very good evening, everyone. A warm welcome to all our respected faculty, distinguished doctors, and participants joining us from across the country. On behalf of International Association for Integrated Oncology, IAIO, I'm Roshni and I'm delighted to be your compare for today's session under the IAIO Expert Insights on Genitourinary Cancers. Today's focus theme is endometrial cancers, still confused how to manage. A topic that is clinically relevant and extremely important in our day to day oncology practice. We are truly grateful to such an eminent panels of experts who will be help us bring clarity to evolving treatment approaches and practical decision making. Before we begin, it's my privilege to acknowledge and thank our program director, Dr. Akshay Ambada Shivachan sir, founder and chief medical oncologist from Cure Life Cancer Center. Sir, thank you for curating this academic session and for your continued commitment to advancing oncology education through IAIO platforms. Your guidance and leadership make this knowledge sharing initiative possible. To set the context for today's discussion, now I would like to invite the program director of the day, Dr. Akshay Ambadas Shivachan sir, to deliver the introduction and context setting. Sir, the platform is yours.
Yeah. Thank you, Roshni. So, good evening, all. So, actually, the topic we chose today is regarding we are discussing about how to manage endometrial cancer in 2026. Now, we all know the newer drugs have come up, and even in advanced metastatic, also in neoadjuvant setting, and how to manage the exact endometrial cancer patients is a little bit of task in today's era also, because so many confusion when to use molecular diagnostics, when not to use molecular diagnostic, how to uh, treat a case of endometrial cancer in a primary setting or in advanced or metastatic settings. So today we are going to decipher all those facets, all those key points, all those difficult things which we come across in our day-to-day practice, in our OPDs, discussing the treatment options with the endometrial cancer patients. So today we have expert panel. We have our moderator, Dr. Tejinder Singh sir. We have Dr. Pushpak. Myself, I'll be talking on the locally advanced and metastatic endometrium management. So, without much delay, I would like to start the session, today's session, and I'll hand over to the Roshni. Roshni, over to you. Just introduce first speaker, and we'll start.
Okay, sir. There is a connectivity issue from Pushpak, sir. So, if that's okay, could we start with your session, sir?
Sure, sure, sure. I'll be happy. I'll be happy to do that. No issue, Roshni.
Okay, sir.
I'll just share my screen. Just
Yes, sir.
shall I start my sharing?
Yes, sir, please, sir.
Is it visible?
Yes, sir, it's visible.
Yeah. So good evening all. So today I'll be discussing about some important aspect, that is management of advanced stage and metastatic endometrial cancer. And so today's topic outline will be like introduction and epidemiology, a few slides on that, local advanced endometrium, and some metastatic and recurrent carcinoma of endometrium. Now, we all know it's a cumulative risk in India. It's almost fourth common cancer. In India, almost 3.9% is the cumulative risk. Just a second. So, yes. So it's among uterus breast cancer is also rising among younger women. Also, it's some part of Bangalore. You can see the news article, and corpus uteri or cervical, sorry, the endometrial cancer is the one of the most common cancers in India. Now, if you see the advanced and recurrent endometrial cancer, major challenge being that the 5-year overall survival rates of only 17% with distant metastasis, approximately 60 to 80% early stage endometrial cancer 5-year OS rates of around 95%. Remaining 20 to 40% of women with early stage disease have one or more high risk features. The diagnostic challenge being identifying which patients with early stage endometrial cancer have a low risk disease with a risk of recurrence less than 5%. So it's a major issues in recurrent and advanced settings. If you see the major determinants of treatment, what are the factors that determine the recurrence? The first is age, then histology, endometrioid versus other high risk histologies, grade low versus high grade, myometrial invasion less than 50% versus more than 50%, LVSI, so lymphovascular space invasion, which is a focal or substantial, T size more than 2 centimeter, and of course the lymph node metastasis. So these are some factors which determines the recurrence risk of a patient having C endometrium. Now, a single slide on the roll-up lymph node dissection. If you see the grade 1 tumors involving only endometrium with no evidence of intraperitoneal spread, it is risk of nodal involvement is less than 5%. Grade 2 to 3 invasion less than 50%, 5 to 9% pelvic nodes, no intraperitoneal spread 4%. Patient they are para-aortic. If you go deep muscle invasion, high grade tumors and intraperitoneal spread, if you can see the regional nodes, that is pelvic nodes, almost 20 to 60%, and 1 out of 3 patients they can metastasize the para-aortic nodes. Now, if you see the locally advanced C endometrium, they are stage 3A to 3C. Sometimes stage 4A also comes under that spectrum. And coming to FIGO classification, there are changes in FIGO 2023 staging updates. So they have mentioned that substantial LVSI, the stage migration impact, 30% patients are reclassified, improved 5-year survival prediction, better alignment with the treatment outcomes. They have integrated the molecular pole mutation, P53 abnormality, MMR deficiency, deficient tumor. So they have redefined the classification. But still, if we consider the therapeutic implication, the still NCCN recommends to use FIGO 2009 staging. Now, is the role of NSAT? Most of the time, this point is being discussed in a patients or locally advanced CA endometrium. Is it possible, or is there is a role of any neoadjuvant chemotherapy as we do for our CA ORI patients? Now, there are few trials. Some are phase 2, some are multicenter retrospective, some are pooled phase 2 data. So most of the time the outcomes, if you see the 43% overall response rate, 84% optimal debulking, median PFS of 26 months. But most of the trials, there are sometimes limitation as single arm, small sample, or heterogenic reading regimens. Then there is a publication bias, there's a selection bias. So there is only one prospective cohort, gynecological oncology group 2024. The sample size is very less. So they used chemo plus IO, plus minus IO as a NACT, and they found almost 60% overall response rate with IO, better in DMMR patients. So it's an early data, maybe promising data for those patients where we can choose giving chemo plus IO for those subset of patients of who having DMMR status. Now, if you see the genetic status, we know about the P53 abnormality, MMR deficiency, pole mutant, NSMP. So if you see the NACT response rate, overall response rate, so P53 abnormality, you know, it's aggressive histology, aggressive mutation, chemosensitive, high recurrence risk. MMR deficient or MSI high patient, they have immunotherapy favorable, radiation sensitive. So NACT response rate, if you see 50% overall or 10 to 15% PATH CR, those survival impact is no benefit. Pole mutated, they looked at 70 to 80% overall response rate. They are ultra mutated, de-escalate, we can de-escalate the therapy. So pole mutation is very important. NSMP profile, no specific mutation profile. So PIK3CA resistance or PIK3CA mutated patients, they are under this NSMP, and we will use this frequently in our discussion about these molecular predictors. Now, if you see the adjuvant therapy, we know the PROTECT 3 trials, which has given this data about adjuvant paclitaxel, paclitaxel plus carboplatin. And if you see the traditional risk group based on clinicopathological factors, patients who are high risk, stage 1B, grade 3, stage 3, stage 2, non-endometrial. So pelvic radiotherapy plus chemotherapy is a norm. There is almost 5% absolute overall survival improvement in a patients who have given CTRT versus only RT. So chemotherapy is a part and parcel of stage 3, grade 3 patients where we usually give 4 to 6 cycles of paclitaxel carboplatin. So both histotype and grade assignment have been shown to be poorly reproducible, even this among expert pathologists, with no agreement in histotype diagnosis in one-third of cases. So if you see the PROTECT 3 trial also, there is a discrepancy. There is a still debate regarding what histotype, what is the grade, how the patients were graded. But we know, as per the current guidelines, high risk histologies, high risk patients, almost 15%, they will require pelvic radiotherapy plus chemotherapy. What is the conclusion is locally advanced disease is a systemic disease. Now, what is main important here is a good proper surgery is very important for local control. If your surgery is not good, patient will have locoregional recurrences. There is a definitive role of post-op adjuvant RT and chemo, which has OS benefit. And even if it stage 3 or 4A post-op measurable disease, good evidence and data of IO plus chemo. So we'll go in detail about that part in stage 3 and stage 4A. So it's advanced disease. Now, if you see this management of newly diagnosed or relapsed recurrent endometrial cancers, our area is on the left, on the right hand side of the right. So local recurrence first line or second line. Now, if you see the molecular and genetic signature, so this is classified into four types. So pole ultra mutated, MSI high, copy number low, that is non-specific mutation profile, and copy number high, which is a P53 abnormal. So just remember this chart. They are given the percentage and how these mutations they are important in classification of endometrial cancer and their immunotherapeutic checkpoint inhibitor responses, prognosis. So if you know the spectrum from pole ultra mutated on the left hand side to the P53, the recurrence rate and the prognosis becomes more bad. So pole mutated have excellent prognosis as against P53 abnormality, they have poor prognosis. In between MSI high, they have intermediate prognosis, high immunocheckpoint inhibitor response for MSI high DMMR patients. And this copy number low, they have more of P10 mutation, PIK3CA mutation, CTNNB1 mutations. They have low tumor mutation burden. They have variable immune checkpoint inhibitor responses. Now, this chart will come again and again in subsequent slides. So this is something, it's a TCGA subtype, and they have shown that which are the mutation, which are the subgroup of advanced patient which we can choose for our therapy. Now, in coming to the recurrent metastatic, what are the first line options we have is a chemotherapy, immunotherapy, immunotherapy plus anti-VEGF, chemotherapy plus anti-VEGF. So we'll go one by one. In a metastatic disease, the chemotherapy part, the GOG 0209 is the trial which can which had showed that there is no added advantage of addition of cisplatin doxorubicin to taxane. Rather than we can switch to doublet. So Taxol carbo, which gives equal PFS, equal OS with the advent of very less toxicity. So the norm now, as far as chemotherapy is considered, we give paclitaxel carboplatin based chemotherapy for locally for advanced or metastatic disease, which has based on the GOG 0209 trial. So this was the trial. Now, what are the immunotherapy landmark trials we have? So, which has transformed the endometrial cancer treatment in recurrent and metastatic settings. So, we have three trials. So, NRG-GY01, that is Keynote 868 with pembrolizumab plus chemotherapy, which has demonstrated 70% risk reduction in DMMR disease and 46% in PMMR. Ruby trial, we have dostarlimab plus chemotherapy. We have Keynote 775, which is in a second line, that is lenvatinib plus pembrolizumab in PMMR disease after platinum progression. So these are some landmark immunotherapy trials. If you see the NRG GY08 pembrolizumab plus chemotherapy, so they are divided into two groups. Pembro plus chemo versus only chemo, followed by pembrolizumab maintenance. They were included stage 3, 4A, 4B, any histology except carcinosarcoma. So carcinosarcoma patients are excluded. So primary endpoint being PFS, secondary endpoint being safety, overall response rate in the DOR treatment arm, MMR, IC status, OS in PMMR and DMMR. So if you see both cohorts, PFS in DMMR as well as PMMR, both are getting benefited. So addition of pembrolizumab to standard of choice chemotherapy followed by pembrolizumab maintenance resulted in almost 70% and 46% reduction in the risk of disease progression. So if you see the hazard ratio of being 0.3 versus and 0.54. So this has shown a very good PFS advantage. So the HR for progression or death almost 0.3, so 70% decrease in the MMR deficient group and in MMR proficient group. So both favoring addition of pembrolizumab. Coming to this Ruby trial, where dostarlimab, it has been approved in 2023 for patients with primary advanced or recurrent endometrial cancer that has MSI high status. But what about PMMR status? So they have looked at both the subgroups. So dostarlimab plus chemotherapy followed by dostarlimab every 6 weekly for up to 3 years versus chemotherapy. Now, if you see the overall population, DMMR patients as well as PMMR patients. So, overall population also the hazard ratio of 0.64, so almost 36% reduction in the progression. So, if you see the difference is maximum in DMMR patients where they have found hazard ratio of 0.28 with So benefit is greater in DMMR subset, but overall population, if you see, it's getting benefited. So coming to OS data, so trend is favoring dostarlimab plus chemotherapy versus placebo in seen for OS also in PMMR status. DMMR is already shown the OS benefit. So 2-year OS rates, if you see, uh, almost 83.3% in dostarlimab plus chemo versus 58.7% in placebo plus chemotherapy arm. Now coming to this trial, ATTEND trial, that is NGOT EN7 Mango study design, that is atezolizumab plus paclitaxel. So they have looked at paclitaxel plus atezolizumab versus plus atezolizumab maintenance, where they have newly diagnosed or recurrent endometrial carcinomas, the patient's subset. So here also they have found the similar results in DMMR PFS advantage, also the OS advantage. Now, if you see the subset, that is PMMR, where this regimen has not found beneficial. So for PMMR patients, atezolizumab is not going to work. It has not worked in the trial too. So almost HR, you can see 0.92 with inclusion of unity, that is 1.16. So for DMMR, yes, it's a good choice, but not for PMMR. These are some subgroup analysis. Sorry for the busy slides, but it's for DMMR. So something which has failed in first line and passed in second line. So what is that regimen? Is the lenvatinib plus pembrolizumab, which has not shown benefit in the first line, but post platinum it has shown advantage, and irrespective of MMR status, we can use lenvatinib plus pembrolizumab in second line setting. Now coming to Duo E, which is a buzz nowadays, durvalumab plus chemo followed by durvalumab plus olaparib maintenance. What they have found, this is something synergistic effect durvalumab and olaparib. So olaparib enhances the efficacy of durvalumab. So they make the immune cold tumor to immune hot tumor, so that durvalumab is going to act. So there are three arms. First is durva plus chemo. Second is chemo only plus placebo. Third is uh, chemo plus durvalumab followed by durva ola and only durva maintenance. So they have looked at all these three groups, and they have found that durva plus chemo followed by durva plus olaparib, they have shown superior results versus control arm. Now, what are the options we have post paclitaxel? We have single agent paclitaxel, bevacizumab, ifosfamide, docetaxel, with the overall response rate ranges from 9% to 27%. So there were no too many options in second line, but the lenvatinib pembrolizumab has shown very good results. Now, second line IO, what we were discussing is Keynote 775. So lenvatinib 20 milligram plus pembrolizumab, which had shown FDA got an accelerated approval for this regimen for second line advanced and metastatic endometrial cancer patients. Now, this has shown all participants hazard ratio of 0.56, almost 44% reduction in progression and death. So, be it a DMMR or PMMR in second line, this regimen is going to work, lenvatinib plus pembrolizumab. Now, if you see the tumor histology, post hoc analysis, they have included clear cell, they have included serous, they have included endometrial. So, in these subset of patients also, the regimen has worked. Now, if you see the HER2 testing in endometrial cancer, almost we know that this is a marker in serous endometrial cancer is positive. Almost 25 to 30% of the serous endometrial cases, they have HER2 overexpression. So yes, trastuzumab, this is a phase 2 trial where paclitaxel versus paclitaxel trastuzumab in uterine serous carcinomas, they have found superior PFS advantage after addition of trastuzumab in the chemotherapy arm. There is a small retrospective phase 2 data of paclitaxel, carboplatin, and bevacizumab in advanced and recurrent endometrial cancers. So yes, we do use bevacizumab also. Coming to what is ER status, we usually for a low tumor burden patients, we do see hormone receptor status, that is whether ER or PR positive. And we have the hormonal therapies available for those patients who are not having too much disease burden, where we can use anastrozole, tamoxifen, or majestol acetate, alternating with tamoxifen. So almost 27 to 33% response rates are there. Coming to this trial, that is paleo trial, where they used palbociclib plus letrozole. One of my patient is on the same regimen and getting benefited. So yes, patients who are hormone receptor positive, where we can use palbociclib plus letrozole as we use in a breast cancer patients. Almost they have shown PFS advantage. So 8.3 months versus 3 months. So almost, if you see the disease control rate, almost 63.6% as compared to only letrozole. So this is something randomized phase 2 paleo trial assessed palbo plus letro in advanced recurrent endometrial cancer. Now coming to this P10 mutations. So P10 mutations is so GOG 3007. They have used everolimus plus letrozole or majestral acetate, tamoxifen. So though low number, but if you see the response rate, they almost 24% clinical benefit ratio of 78%. So yes, the few patients where P10 mutations are there, we can use everolimus as our PIK3CA mutated. We know the alpelisib we use in our breast cancer patients. So this is a trial of alpelisib combination along with letrozole. It's a phase 2 trial, uh, alpaca trial. So yes, they have shown that addition of alpelisib to the letrozole, uh, they improved the overall response rate and PFS. So TP53 mutation, if you see, there's something called selenexor. So exportin 1 is the major nuclear export protein for tumor suppressor proteins. So inhibition of XP1 results in increase in the nuclear levels and activation of TSPs, reduction of oncoprotein levels. Now selenexor is the oral selective XPO1 inhibitor. It's a preclinical data is there. So this is something selenexor selenexor patient CENDO trial, which has shown almost 13.7 months median PFS. So yes, there is a hope for PP3 mutated patients. Now this is something called navtemadlin, where it's a randomized two-part trials in advanced and recurrent endometrial cancer, where they looked at TP53 wild type patients, and still the results are not yet out. So these are something for wild type. This is for mutated. We know the synthetic lethality. This is P53 mutation and WEE1 inhibition. WEE1 regulates the G2M phase checkpoints. Now what we have, that WEE1 inhibitor is adavosertib in uterine serous cancer. So they are all P53 mutated. If you see, duration of response is almost 6.2 months with clinical benefit ratio of 38.2%. Now, what are the few more newer modalities in CA endometrium? If you see, we have Destiny Pan Tumor 2 trial, where TDXD has shown good benefit for those who are HER2 expressing solid tumors. So they are IHC 3 plus or FISH positive patients. If you see the endometrial data, almost 57.5% confirmed overall response rate overall. And if you see the IHC 3 plus, this is almost 84.6% response rate with the help of TDXD. So yes, in HER2 positive serous patients in metastatic setting, good to go to use TDXD for our patients. Now, this is something newer, Destiny Endometrial 01. It will examine the TDXD plus rilvegostomig or pembrolizumab in HER2 positive pMMR endometrial cancer. So the results are still awaited. Now, do we have anything for patients who deny for chemotherapy? But that is only in dMMR. We don't have anything for pMMR because chemotherapy being the backbone of the therapy. So single agent immunotherapies in recurrent endometrial cancer, where we have dMMR status. There are two trials, Keynote 158, pembrolizumab monotherapy versus Garnet trial, the dostarlimab monotherapy. If you see the overall response rate, almost they have 48 percent versus 43.4%. So yes, the patients who are frail, old, deny chemotherapy, but they have DMMR status, we can advise single agent immunotherapies in recurrent endometrial cancer. This is something translational. I tried in one of my patient cabozantinib in combination with nivolumab in advanced recurrent metastatic endometrial cancer. So when patients failed on first, second, third line, these are some case studies, or these are some data where we can use cabozantinib plus nivolumab in patients. So what is DMMR versus PMMR? If you see uh, in metastatic setting, if you first line, probably we will not see whether patient is on DMM or PMR state, because we have a good strong data of dostarlimab plus chemo. We have good data of durvalumab plus chemo. We have good data of pembrolizumab plus chemo. So yes, so for those, both subgroup is getting benefited. Only those patients where are frail, where we want to use single agent immunotherapy, where we can see the patient whether it's a PMM or a DMR status. And in second line post platinum, irrespective of DMM or PMR, we can use lenvatinib plus pembrolizumab. Now, what is the revision? What we have learned is the same. It is just summarized in a chart form. So these are some trials in DMMR MSA high patients, PD-L1 antagonist and PD-L1 antagonist. These are something which are HER2. And coming to this part, so these are our group of patients, localized recurrence or systemic recurrence. The first line, second line options we have. So what is the take home for today's is endometrial cancer have relatively high proportion of TMB high, MMR deficient, MSI high tumors, providing rationale for treatment with checkpoint inhibitors. The MSI high and DMMR phenotype has emerged as a predictive biomarkers for checkpoint inhibitor therapy. A number of checkpoint inhibitor has shown efficacy as a monotherapy for DMMR tumors. Checkpoint inhibitor in combination with anti-angiogenic drug have shown compelling activity, which has led to regulatory approvals and large number of trials studying immune checkpoint inhibitors in different endometrial cancer settings that will continue paving the treatment pathway. So thank you so much. Uh, I'm sure I would have done some justice to the topic of recurrent metastatic and locally advanced CA endometrium. Over to you, Roshni.
Thank you so much for the interesting session. So, if any of the participants is having any questions, kindly drop in the chat box. We will be taking up at the end of the session. Without the further ado, I would like to move on to our next session of the day. We now move on to our next scientific topic. To deliver this important session, I'm pleased to invite Dr. Pushpak sir. Who is the founder and director of PCC Cancer Care and Research Center from Navi Mumbai. Sir, over to you, please.
Akshay, you want me to do the panel if you want?
I'll just check with Sir Pushpa. I think he just messaged me, so I think he'll be there. Just a second, sir. Give me a
Okay.
minute.
Because if he's taking time, then we'll finish off with our panel discussion. Because our panelists have all come, I think so.
Yes, yes, sir. Yes. Give me just 30 seconds. Yes, sir. We can go ahead with
Shall I present my
sir.
thing?
Yes.
Okay.
I think you have. Yes.
Yeah. So I think I can see Dr. Gaurav, Dr. Jay, and Akash. Rukmani are the only pathologists, and Dr. Hani Parikh is there. So, welcome everyone. Hope my slides are visible.
Yes, sir.
Okay, and my voice is also audible.
Yes, sir.
So, we will try to see what he had discussed. Uh, Akshay has mentioned about the small topic, which I think day by day we're discussing a lot about the molecular and precision. Today we are going to have some kind of some case-based discussion, and we'll try to find out the answers for most of the questions which we are looking at it. So, my first case is about a 58-year-old female post-menopausal bleeding for the last 1 month. Pain in abdomen, scan showed endometrial mass with multiple omental nodules. And this is the finding. Basically, she underwent surgery for the mass. Bilateral fallopian tubes are free. Lymph node, you see, there is only 1 out of 11 lymph nodes showed metastatic deposits. Sigmoid colon mesentery, everything is normal. So these are all, and patient also had hepatic surface deposit, right iliac fossa mass also. So let me start from the Gaurav. Gaurav is there, I think. Gaurav or Akash.
Yes, sir, I'm there.
Gaurav. So basically, she is CA endometrium. She is a case of CA endometrium,
Right.
and with liver, I will say surface deposit, multiple nodes involved. How will you
Right.
proceed in this case?
So, considering the metastatic deposits or mental deposits, staging wise, it's a stage 4 disease. So, I think we should start with the palliative chemotherapy with or without immunotherapy.
Right, right. So in a this kind of stage where you have done a cytoreductive surgery, I won't call it stage 4. This is more of a omental nodules, because the staging for endometrium is almost similar to it. Will you still give this patient's immunotherapy, or you will not give immunotherapy?
So I have seen a few of my patients with such a scenario, and they have very high chances of recurrences. I have seen patients with the surgery, even if after the surgery, even if after chemotherapy of 6 cycles of paclicarbo, they usually recur with like after like 1 or 2 years, within 1 or 2 years. So I think considering high risk, we can still think on adding immunotherapy.
Akash, anyone having different thoughts?
Yes, sir. First thing, even if we do not call it stage 4, but it is stage 3 at least. So, in locally advanced endometrial cancer, we can go ahead with immunotherapy in combination with chemotherapy also. But for that, I would like to have NGS mutation panel and MSI testing along with that. So, according to the our molecular classification, we can go ahead with the combination of treatment. What we can explain to our patient also.
Dr. Jay, any different thoughts?
So,
Or
sir,
you will give immuno, like both of them are quite okay in giving immuno to this kind of patient, which is more of stage 3. Not,
yeah,
it is a liver surface mets, and patient is having, we had done a R0 resection. It has come as endometrioid adenocarcinoma. Or you are looking for other, Akshay has mentioned so many mutation, or you will wait for the mutation analysis before you do it.
we'll do the mutation panel. That is the basic endometrial panel. And also, sir, I want to know, I want to add that I will give 3 cycles of chemotherapy plus immunotherapy, then radiation. It's like a sandwich. That is what I practice, sandwich radiation. And again, 3 cycles as adjuvant, followed by immunotherapy maintenance. This is what I practice.
Dr. Rukmini, I think you are the pathologist here. In a stage 3
Yes, sir.
patient, what happens is that you decide on the basis of histology to look for different mutation, or you go ahead with the pole mutation, P53, everything you check it.
Uh, Actually, now because pole mutation has become like a norm for deciding or de-escalating the therapy. So all the high-grade tumors, we usually go for pole, like in the algorithm. First pole, then we go for MSI, and then we go for P53. So this has become a norm.
Okay. I'll come to that answer later on. Maybe I'll have time, then I'll discuss about it. Dr. Hani Parekh, any different thoughts from your side, or you will go and give RT to this patient post chemotherapy?
Hello.
Yeah. Will you give IO in this patient?
Sorry, sir. Actually, can you please
Okay,
repeat the
I'll
question?
just repeat. There is a patient 53, 54 years old. Omental deposit, high grade adenocarcinoma has come. Basically, it's a endometrial high grade adenocarcinoma. Multiple mesenteric nodes, multiple some amount of retroperitoneal lymph nodes, but it's liver surface deposits. Underwent CRS, complete CRS basically. Will you give IO, and is there any role of RT in this patient radiation? So it is a endometrial
So,
endometrioid adenocarcinoma.
so yes, sir. I would like to add IO with chemotherapy in this patient, and the report, like the liver surface and all things are positive in the histopathology after CRS.
Yeah. It's a R0 resection.
Okay, okay, okay. So I would like to add pembrolizumab along with chemo.
Okay, so
IO.
you will give pembro irrespective of any mutation testing, or will you wait for the mutation testing to
No,
come?
I would like to go for NGS panel, and then I would like to add IO.
So, we'll come to that question. Basically, if you see Akshay has mentioned four different kind of variety. We look into the P53. We look into
Pole, yeah.
pole also. We look into the non-specific one, and the last is a DMMR. So my question
Yeah.
here is basic, very clear. In stage 3, is there any role of IO? This is not a stage 4.
Yeah. So yes, so there is role of IO in stage 3 also. Like perioperative or adjuvant setting, there is role of IO.
Akshay, you want to add? You are also here. You are the coordinator, so you have to be here.
Yes, I'm here only.
Tell me, what is your opinion? Two questions I am going to put up. I will tell you there is no role of radiation in this patient. This is not a
So
localized.
this patient, so this
Yeah.
patient is being treated as a curative intent. There is a R0 resection. Patient, surgeon has done very good job. So in this patient, we'll go with whatever the adjuvant protocol, what we follow. So my take is chemo and radiation.
Yeah. So basically, we had our own tumor board discussion. There were 2 points which we came into it. One thing is very sure that when you see the ESMO guideline, stage 3, stage 4 patients, we don't do the molecular testing. It doesn't add to anything. The pole is only meant for stage 1 and 2. I'll show you the guidelines also. Pole is not so much important for stage 3, stage 4 patient, that too with a high grade. P53 in a stage 4 has got no meaning also. Second thing is that radiation role is not there, because what you are going to radiate when you are having a stage 4 disease, which is more of a high grade, which is behaving like a, we have done a CRS. And lastly, till now, even though there might be some data which might come up in the place, there is no role of any kind of IO in the treatment of stage 3 patient. We are giving only the paclicarbo based chemotherapy, and we do the testing for DMMR. The purpose of doing a DMR is only for to find the Lynch syndrome, nothing more than that. So this is my understanding. My question to everyone, starting from Dr. Hani, will you do a BRCA testing in this patient?
Uh, so like genetic germline BRCA?
Yeah.
Germline BRCA.
Or you want to do HRR? It's also okay. Will you do the BRCA mutation?
I would like to go for HRR rather than BRCA.
Okay. And Dr. Jay, Akash, anyone can take this question?
So looking at the presentation, it more looks like to be a ovarian cancer. If
No,
that is correct.
this is endometrial.
Or
This is not
it
ovarian.
can be a synchronous also, I think so. And it's a stage 4 disease, but
No,
we are
no, no.
going for
No,
curative.
Jay, I think I'll not go into it. I'll tell you very
Okay.
clearly in the uterine endometrium also there's a variety called serous adenocarcinoma, right?
Yeah,
So
serous
don't
adenocarcinoma.
this is not a
So for
serous
that we have to
adenocarcinoma.
do HER2 testing also, sir.
So that is this patient is purely endometrial cancer, no ovary.
Okay. Okay.
So my
So
question
sir,
is that will you do a BRCA testing or not? My question is clear.
no sir, I would do a broader panel if I have to
No,
do,
I am not
not
taking
only
exam for
BRCA.
you. I am not taking exam for you. Will you?
No,
You will
I
not
would
do it.
go for BRCA. I will go for a broader panel.
You will
Only
go for
BRCA
broader
I
panel.
don't. Yeah.
Anyone, Akash or Rukmini, will you? Acha, Rukmini is only pathology. Akash, you can answer. BRCA or no?
Yes, sir. BRCA.
Okay. So I'll just give you one brief also. I know, all of us are reading now endometrium a lot. In endometrium, there is no role of doing a BRCA testing. Only one variety where you can think about doing a BRCA testing is serous adenocarcinoma. Remember, this serous is different from the serous ovarian cancer. So you see a endometrial cancer, you have a variety called high-grade endometrioid adenocarcinoma, the one which we have seen. Second is called high-grade serous adenocarcinoma. Third thing is carcinosarcoma. These are the three ways we look into it. BRCA testing has got no importance in endometrial cancer. We'll come to that point also, but there's no role for it. There's no role of even doing HRR. We are looking more for Lynch. Our goal of doing a DMMR in this patient is not to see whether we can give immunotherapy or not. Our goal of doing a DMMR in a stage 3 patient with a curative intent is only to look for whether this patient is having a Lynch or not. If a patient DMMR is positive, then we have to do a germline Lynch testing to find whether it is Lynch or not. So Akash, this is a patient who is PMMR, ERPR is positive, P53 mutated, HER2 negative. Will you do HER2 testing in this patient?
HER2 is already done, sir.
Ideally, will you do it or no?
Yes, sir. According to guideline, I will do HER2, but
Basically,
not in stage 3, but in stage 4, there is role of anti-HER2 treatment. So in stage 4, but not in stage 3.
Yeah. So what is important, what you said is very right. Normally HER2 is not recommended for a stage 3 patient, for stage 4. And we don't do HER2 testing. But here the important thing is, since this patient is ERPR positive, Akash, will you give maintenance any kind of anti-hormone therapy?
Yes, sir. But after giving our adjuvant chemotherapy, I would like to see the grading in our histopathology.
This is high
If the
grade.
tumor.
This is high grade endometrioid adenocarcinoma.
Okay, so if it is high grade, then I would like to omit the hormone therapy at present. But previously, I have given hormonal treatment even in high grade also, but I don't know the actual benefit. But according to guideline, only chemotherapy will be suffice for this patient.
Agreed. I think Akash has been very bang on very simple point. Only for the low grade adenocarcinomas, we do give the anti-hormone therapy. Otherwise, it is not required. Even though they are ERPR positive, we are tempted to give it, but the benefit is not there. You can read ESMO is very clear about certain guidelines. I think you can go through it. Everything is very clear about it. So this patient basically is a case of endometrioid. We had just given them very clearly. Only we had given them Paclitaxel. I agree with since it is PMMR, there is right now Lynch. We not look into it. Even though P53, we are not bothered about the P53 in a stage 3-4 patient. This is the final wordings of the ESMO. Stage 3 and 4 are based on the anatomical staging. The stage category is not modified by molecular classification. Very nicely written, stage 3 and 4. Molecular classification will not make them change even though we need to classify if molecular report is there. When the molecular classification is known, it should be recorded as stage 3 mutated or whatever M or a molecular type is there. And based on that, you can say stage 3 P53 abnormal type. But it will not make any change in the treatment because ESMO is also very clear. Anyway, a second case, 65-year-old female, post-menopausal bleeding, uterine mass. This is what the final report looks like. and the tumor is 3.3 by 2.7 centimeter. Myometrial is more than 50% involved. So, and I think the final report is CA endometrium, adenocarcinoma, grade 2 on frozen section. Myometrial invasion is more than 50%. Tumor is seen invading the stroma. Parametrium are not involved, and all the nodes are all negative. So this is just to highlight that this patient has got a LVSI and ERPR is positive, and P53 is also wild type. And you can see here the DMMR. There's a loss of MMR, so this patient is DMMR. Final, this is just to give you an idea. PT2N0, LVSI is there, stage 2, but DMMR. So how many of you, Rukmani, you are the only pathologist. Does the medical oncologist ask for this substantial LVSI, or they just want to ask from you only LVSI?
I don't think everybody knows about this. So usually they don't ask. But
Okay.
like
But
whoever
have you,
knows, they ask. But yeah, we have started reporting it, but it has not become like everybody doesn't ask for a substantial LVSI. But after FIGO 2023, like we are trying to put that in our report.
yeah, but I think what you said is very right. Nobody, we also are day by day, our reports are all coming with the, we don't even ask for only plain LVSI. We want this
Yes.
particular word called substantial
Substantial
LVSI.
LVSI.
Yeah,
Yeah.
which is 4 or more LVSI. Having only LVSI doesn't make any sense.
Yes.
You need to have a substantial LVSI because this is a high risk feature. If focal
Yes.
LVSI has got no meaning, it doesn't impact on the prognosis. So, just Akash, one simple thing, any other molecular test is required in this patient? So this patient is DMMR, P53 wild type, T2 disease, that's all.
Sir, it's deficient MMR or
Deficient MMR.
huh?
Deficient MMR.
Okay, so in
I'll show you the
deficient
report.
MMR,
So you can
no,
see.
I don't think I will require further testing.
Okay. Anyone from the Dr. Hani is there? Hani or Jay?
Yes, sir.
Yeah.
Family, we need to do for hereditary check for the hereditary
Pardon?
mutations. Hereditary germline panels. We need to
Germline
do.
panel will do. Germline panel for what?
For Lynch syndrome.
Lynch syndrome. So my take here is very clear. Why I'm asking is pole is very important. You know, DMMR comes into the intermediate prognosis. It is not a bad prognosis. It comes into intermediate prognosis. Pole is very important. Here the pole matters a lot. If the patient is requiring, if the patient is having a pole mutation, you don't require to give radiation also. You don't require to add any kind of brachytherapy also. If the pole is not mutated, since it is T2, more than 50% involved, radiation brachytherapy will be part and parcel of it. DMMR in an early stage, you need not give any, DMMR will not make you add any kind of chemotherapy. So it's a early stage, DMMR will not make our change any therapy, but if the pole comes positive here, you need not add the radiation also. Pole is required. Pole upstages everything. So this patient has got a non-mutated pole. This is a bottom line I'm just telling you. In a patient who has got a pole mutation, pole-driven tumors with more than one classification features, pole overrides everything. If the patient has got a P53 also, it doesn't matter. Even if a patient has got a DMMR, pole is more important. Pole makes it that you don't require to add anything. So in this kind of patient, pole is very much required. You can avoid giving brachytherapy for this patient. So nowadays, day by day, the number of pole mutation, these are all hotspot mutation. So Rukmini, you are getting all this, you are doing in your thing, your pole mutation day by day?
We don't have in our lab. We send it outside, so we don't have the at our hospital now. So we are outsourcing it.
Yeah. So how much is the turnaround time?
Turnaround time, I can't tell about that because it's usually it is sent by the clinician side. I mean, they just
Yeah.
take the tissue and yeah, so I won't be able to tell you.
Yeah. So I think the most important for all of us to understand in a early endometrial cancer is that we don't require to send the broad panel. I think Akshay has mentioned very nicely first, second, third, and fourth step. You only have to do three things: P53 pole and your MMR. You need not have a broad spectrum of all the NGS. NGS, many times we can send a, this is a hotspot. If you see, right, Rukmani, these are all hotspot mutation. These are not like broad panel NGS will pick up. These are all hotspot. And they signify a very favorable prognosis. You can avoid any issues related to like brachytherapy or not. So I'll not go too much into it. If time permits, I'll take one more case. And remember one thing, the POTEC trial basically looked into the poll, trying to see which is the best case. So this patient who we saw it, T2N0 disease, DMMR, she presented later on with right side external mass. You can see, you can see the mass. Can you see this? Two lymph nodes here. So after 3 years, she presented with lymph nodes on the right external iliac. So my question to Dr. Jay or Gaurav is there. Will you repeat the molecular testing, or you're happy with P53, DMMR or POL? This patient was POL non-mutated. Gaurav.
If it was not done, I would like to do it, sir. But if it is done
This
already,
patient is DMMR.
DMMR, then no need, sir. I think I'll be just starting with immunotherapy.
Okay. Dr. Jay?
Sir, what was the time of relapse?
But this, if you see the timing around 2 to 3 years, 2 to 3 years.
Sir, I will repeat.
You will repeat.
Yeah.
And Akash?
No, sir. There is no need to repeat the molecular testing.
Dr. Hani?
So I would like to repeat the with new biopsy.
Right. So, Rukmani, my question to you is very clear. Does the DMMR, because here the DMMR is more important than anything else, does the DMMR change over a period of time, or it remains stable?
DMMR might change.
So the guidelines are very clear, it doesn't change so much. It doesn't change the DMMR because
Okay.
it says that it doesn't change from a deficient to proliferation or proliferation to deficient. And so repeating DMMR even after 2-3 years, it doesn't make any change. So somebody had asked a question for case 2, molecular testing for MSI not required. Basically, you see the word called MSI high or or MSI DMMR, both are same like that. DMMR and MSI high are one and same. Akshay, again a question to you. Will you repeat the molecular testing?
No, sir, no. So probably it won't change.
Okay.
I will not go for repeating molecular uh, testing. Sometimes I do get HER2 loss. If patient is HER2 positive, serous high grade. So one of my patient at progression, when I repeated the sample for HER2, it gets negative. It's not like that in breast. Once a HER2 positive is always HER2 positive. Here it can change.
No, even breast it changes. The question is that we don't accept it. In the sense that if a patient is HER2 negative, it becomes HER2 positive, we treat like a HER2 positive. If a patient is HER2
Yeah.
positive, becomes HER2 negative, we still treat as an anti-HER2. Here also the issue with the HER2 is only one. The
Yeah.
HER2 testing for a endometrium, the staining pattern is different. It's like a gastric pattern. It's not like a
Yes.
breast pattern. This
For
I
all
think we need to
solid.
be very
Yeah.
clear. Second thing is
Yes.
that there is nothing called low HER2 or pattern in a endometrium or ovary also. And third thing is HER2
Yes.
is a very heterogeneous tumor. You might hit one spot which is negative, one spot which is positive. It's like a gastric one. The purpose is very clear. Multiple biopsy has to be taken, then only we'll get it. So the rule here is also very clear.
Yes.
I agree. But this patient, ultimately, the biopsy showed serous high-grade adenocarcinoma. Any change of thoughts for you? Or you will continue giving DMMR?
So patient is already having DMMR.
Hmm.
So
So basically somebody did, it has come as MSI stable. That's a different thing now.
I-
Ideally, the MMR doesn't change. That is to my knowledge. It doesn't change so much.
just wanted to
Can we
know
go
from
for PDL1
pathologist.
here?
So
PDL1 can be done here.
PDLV has got, if my knowledge is that PDL1 has got no usage in the endometrial cancers. It is
So
MSI which matters.
So in metastatic sites, like if there is MATS, is PDL1 because it's written in our cap, like mostly it's done in serous because this came out to be a serous carcinoma.
So serous,
So
remember this is endometrial serous. This is not a ovarian serous. Again, I'm using a word. If you see the uncommon tumors of C endometrium, no,
yeah,
the serous is there, but they behave differently than the ovarian
but
cancer.
serous is like endometrial serous is always a high grade tumor.
They are high grade. All serous are high grade. My question is that
No, the
endometrial high
difference
grade
between
serous is different from the ovarian serous.
yeah, ovarian we have a low and high, but in endometrium we always have a high.
Yes,
We
yes,
don't have a
yes,
low grade. Yeah.
yes. Endometrial, the serous histopathology is different from the ovarian serous. That is what I am going on telling, that the pattern of molecular pattern is also different. So anyway, this patient was P53 mutated, ER/PR positive. So Akash, you will treat it like a curative intent or you will go for palliative intent?
Sir, here the only involvement is nodal disease only. So after giving some form of chemotherapy, I think it is DMMR, sir.
No, now it is PMMR,
And
MSI
now it is
MSS.
PMMR. Okay. So after giving some form of chemotherapy, after giving 3-4 cycles or 6 cycles of chemotherapy, I will repeat the scan, and according to that, I will involve my radiation oncologist uh, to give some form of radiation if I want to give the curative benefit. Then
Okay. Jay, your different thoughts. Will you involve a surgeon to again operate?
Yes, sir. Will at least involve him in the decision making.
Dr. Honey, is there any role of doing a HIPAC in this patient?
So, sir, it depends on the response of the chemotherapy, what we get, and if there is like good response and the size wise are optimally reduced, we can always discuss with the surgical oncologist. But I don't think in endometrial, I'm not sure. Like obviously in ovary, we are very much comfortable going for HIPEC. Uh, I don't have much idea or with HIPEC in endometrial, like how it responds and.
Right. Gaurav, any different thoughts?
Depends, sir. Like controversial situation, like doing HIPEC in such situation. So depends totally upon the center where we are
Yeah.
practicing.
So this patient, basically we gave 3 cycles of paclicarbo. She had a wonderful response, and we took this patient for secondary cytoreductive surgery. I agree with Hani is that HIPEC is still evolving, but the pattern of behavior in HIPEC and endometrial is not there. But we did a secondary cytoreductive surgery. So my question is that post surgery, is there any role of radiation? Anyone can take up, Dr. Jay, any role of radiation here?
No, sir.
Okay. So I think the question came here was basically, since it was a recurrent disease, whether we should have added immunotherapy to it or not, because DEO is now coming up with a very nice data about giving this is, I think all of us know, DEO versus 3-arm study where they are given on maintenance BRCA, we have given certain things like PARP inhibitors also. So I think if time permits, I'll take one more case. This is the last case before we'll wind up. This is a case of a CA endometrium. You can see a endometrial mass. Plus, this patient presented with the right femoral deposit, and this patient also had a serosal deposit. ER positive PMMR. Gaurav, will you treat this patient on a palliative intent or curative intent?
What is the age of the patient, sir?
He is 68 years.
And And this is like single isolated
So
metastatic.
this is she presented to me with basically this mass, later on found to have endometrium. So this is a serial deposit on the right iliac fossa and
Okay.
also having a bony lesion.
Okay. So, like considering the bony lesion and the age of the patient 68, I will like start with the chemotherapy, sir, initially, even if the because age of the patient permits the chemotherapy.
Yeah. So basically we gave 4 cycles of paclicarbo. You can see here the bony lesion has almost disappeared. Uterine mass has come down. Serosal deposit has come down. Dr. Hani, will you take this patient for surgery, or will I had given this patient Durva plus paclicarbo, honestly. Metastatic
Okay.
disease. So will you avoid doing any surgery, or will you just give only Durva and continue with it?
So, like, so being a medical oncologist, I would be happy giving Durva if the response is so good. But I would definitely discuss with the family, like if they want, and depending on the ECOG performance of the patient, like can he go for like vast, because he needs a total replacement for a femoral lesion and then the liver and all. So it all depends on the ECOG performance of the patient and willingness for curative intent or not. Otherwise, I would be comfortable with giving Durva to the patient.
Dr. Jay?
So we'll be treating as a metastatic disease and won't consider any for surgical intervention.
Yeah. So basically, we treated this patient as a oligomet, honestly. We had Akshay. Well, Akshay, you are there,
Uh,
na? We had discussed this case
yes,
when you were also
yes,
there.
yes.
But I feel that, endometrial is one funny disease where you should do whatever is best. We are treating this patient as a oligomet only in the bone.
Yeah,
Bone part, we can give radiation. So we
radiation.
have just now, basically, few days back, she underwent CRS, very good response. But the goal will come here is that, Akshay, if the patient is still having residual or no residual disease, will you continue Durva and how long?
Yes, actually, this is something called treated as NED, no evidence of disease. If patient is getting very good SBRT responses at bone lesion, I'll tend to continue durvalumab maintenance because, as you said, it's a very notorious disease. So if you started with the paclicarbo durva 6 cycles, so I'll just continue with the durva maintenance rather than giving durva plus olaparib.
Yeah. So I think the only problem is that we are planning to see the bony part and give a radiation to the femur part. But I think ovary is now evolving a lot. This is just a give you a brief chart where which area we have to address. Remember, only thing is that the role of endocrine therapy, we do tend to give them anti-hormone therapy for almost every patient, even in ovaries also. But there's no different role except in a endometrium when if it is low grade ER positive. Otherwise, in a high grade tumors, there's no role. And even if the patient is DMMR in the initial setting, there is no role of immunotherapy. There's a data might come in the later on in an early stage, but the data for immunotherapy is more for stage 4, stage 3
So
disease.
data, yes, sir. Data for neoadjuvant is coming for the
Yes,
DMMR
yes,
patients.
yes.
So yes,
And I
uh,
think what you said is very right. For the new adjuvant, it's coming also.
yeah.
But the good thing is that the DMMR in endometrium is behaving differently, because even there is a second line approval for pembro plus lenvatinib, even if the patient is PMMR. And in a DOE they have given Durva to irrespective of DMMR. So they
Yes.
have not seen the DMMR, and based on that, DOE is purely patients who are DMMR. You have to give Durva plus chemo followed by Durva maintenance. Those who are PMMR, you have to give olaparib as maintenance. If I'm right, Akshay.
Yes, 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 definitely, sir.
So the role
And with the
is day by
interest
day.
of time, sir, we'll
Yeah.
just
No, no,
quickly.
it's over. It's over. It's over. Thank you.
Yeah.
Thank
So
you. Thank
Pushpak
you,
is
everyone.
waiting. Yes, yes, yes. So over
Pushpak, we
to.
had taken your time, but I think thank you for giving us time.
Yes, sir. So I just thank all the
Yeah, thank you to all the panelists. Huh? Thank you.
thank you, sir.
Thank you, sir.
We have Dr. Pushpak around, na, Roshni?
Yes, sir, we have, sir.
Yeah.
So, without the further ado, I would like to invite Dr. Pushpak for the talk. Sir, over to you, please.
Yeah, I'm so sorry. I could not join a little earlier. Can somebody share the slide deck, please?
Yes, sir, sharing, sir.
A wonderful discussion by Dr. Tejinder and all the panelists, and indeed a very insightful discussion on endometrial CA. So my role was to present, or I am presenting endometrial cancer adjuvant therapy and how it has changed in the recent years, depending upon the molecular classification. Next slide, please. So, adjuvant therapy in endometrial cancer has changed, and it's now quest for precision. Following hysterectomy, the core challenge in endometrial cancer is to accurately identify patients who will benefit from additional therapy, and the goal being to eliminate the risk of recurrence without subjecting the patients to additional toxicity of unnecessary treatment. This requires a sophisticated evidence-based approach to risk stratification. So the patients that we stratify according to the molecular classification will help us guide better to accurately identify patients who will require additional treatment, that is adjuvant therapy. Next slide, please. So clinical pathological features provide the foundation for risk assessment. So adjuvant treatment decisions traditionally hinge on patients' risk of recurrence, determined by a combination of clinical and pathological features. These factors for stratifying patients are divided into three distinct groups: low risk, intermediate risk, and high risk. The patient-related factors and the disease-related factors are patient age, histologic type, tumor grade, depth of myometrial invasion, lymphovascular space invasion. Typically, the classes are low risk, intermediate risk, and high risk. Um, the low risk will typically requires only surgery. Intermediate risk will focus on loco-regional control. The key is balancing efficiency as well as morbidity. And high risk requires systemic therapy to address the likelihood of distant metastasis. Next slide, please. So the evidence supports de-escalation of treatment for low and intermediate risk disease. For patients with lower risk of disease distant recurrence, the focus is to maximize local control while minimizing treatment-related morbidity. Landmark trials have refined our approach, establishing observation or brachytherapy as a standard of care. So low risk, that is stage 1A, grade 1-2, endometrioid and no LVSI. The recommendation is observation only. Rational recurrence risk is less than or equal to 5%. Adjuvant radiation does not improve overall survival and hence and may increase complications. High intermediate risk defined by the GOG and the POTEC criteria. So the key trial is the POTEC 2 trial, compared vaginal brachytherapy versus external beam. And it found that a vaginal brachytherapy provides equivalent roco-regional control with significantly lower GI toxicity and a better quality of life. VBT is the standard of care for high intermediate risk endometrial cancer. Next slide, please. So high-risk endometrial cancers require systemic therapy to combat the chance of distant metastasis. Patients with high-risk disease, that is stage 3 serous or clear cell histology, face a substantial risk of both locoregional and distant recurrence. Pelvic radiotherapy alone is inadequate. And a critical question has been how to best integrate systemic chemotherapy to improve survival. So high-risk categories include stage 3, 4A disease of any histology. Aggressive histologies like serous clear cell carcinosarcoma, and high-grade endometrial cancers with deep invasion historically. Next slide, please. However, this has also now been refined with the use of certain molecular classifications. Before that, the defining trials for adjuvant treatment for endometrial cancer were the POTEC 3 trial, that is high risk stage 1 to 3. Comparison was done between pelvic artery alone versus chemoradiation. And the key finding was improved 5-year overall survival of 81% versus 76%, and a failure-free survival of 77 versus 69%. The biggest benefit was seen in stage 3 disease, OS 76% versus 69%, and serous cancer over OS of 71 versus 53%. This established the superiority of chemoradiation in high-risk patients. Then came the GOG 258 trial, where stage 3 and 4A disease. So comparison was done between chemoradiation versus chemotherapy alone. And the key finding was no difference in relapse-free or overall survival.
And a crucial detail here, chemotherapy alone resulted in significantly more pelvic and para-aortic nodal recurrences. And hence this supports the decision of use of adjuvant radiation to maintain crucial locoregional control. Next slide, please. So now the paradigm shift, the dawn of molecular classification. So now we are moving from the era of classifying what the cancer looks like to what the cancer actually is. And this has been supported by many molecular data. So the Cancer Genome Atlas provided a key insight to distinct molecular subtypes which are more prognostic than traditional histology and stage. Next slide, please. So, four molecular subtypes fundamentally redefine endometrial cancer. Based on the genomic alteration, endometrial cancer can be classified into four prognostically distinct groups. This classification can be performed on surgical specimen using surrogate markers. If we see endometrial carcinoma, then the flowchart is the pole mutation status known? If the mutation status is wild type, check for MMR status. If the pole is mutated or hypermutated, this is classified as pole mutated endometrial cancer, and which comprises almost 10% of the total endometrial cancer cases. These are usually good phenotypes and are can be criteria to de-escalate treatment. In wild type, check for MMR status. If the MMR status is deficient, then endometrial cancer, MMR deficient, mismatch repair deficient, almost 30% of the cases are MMR deficient. If MMR is proficient, then check for P53 status. If it is wild type, then it is classified as no specific molecular profile, that is NSMP. And if it is mutated, it is P53 abnormal high. And in that, we see for copy number variations, high or low. So P53 abnormal, about 20% of the cases, these behave aggressively like serous carcinomas. Next slide, please. The POTEC3 molecular analysis reveals who truly benefits from intensive therapy. So if we can see here that the 5-year recurrence-free survival as per molecular subtype, the benefit is confined to the group of P53 abnormal, that is addition of chemotherapy to radiation dramatically improved the 5-year RFS of the P53 abnormal patients. So RT alone was 36% and chemo radiation was about 59%. Next slide, please. So if you can see here the previous slide, please. So if you can see here the integrated algorithm merging molecular data with clinico-pathological data, the future of adjuvant therapy lies in the integrated risk profile assessment. So patient with endometrial cancer post-hysterectomy, first we do the pathological assessment and then we do the molecular classification. So if the molecular is pole mutated, say low risk, then suggested option is observation. If it is intermediate risk, combining molecular status as well as clinico-pathological features, say for example, stage 1B MMR deficient, it is high intermediate risk, and then this patient can further be subjected either to vaginal brachy, pelvic RT or chemoradiation. And if you have a high grade or high risk endometrial CA, that is if it is myoinvasive or is P53 mutated, then action recommended is chemoradiation. Next slide, please. Immunotherapy revolution is also transforming care for dMMR tumors. So we all know mismatch deficiency is the agnostic indication for the use of immunotherapy, and this is applicable to endometrial cancer also. And it is a standard of care for advanced recurrent disease, but now is also being evaluated for adjuvant treatment of endometrial CA. Next slide, please. So evidence snapshot, landmark trials affirm checkpoint inhibition and endometrial CA. 2 phase 3 trials have demonstrated unprecedented benefits with the addition of immunotherapy to the first-line chemotherapy. So the one was the Ruby trial, that was the dostarlimab, which was for advanced or recurrent endometrial CA. And then we have the NRG GY018 trial, where was pembrolizumab evaluated for stage 3, stage 4 recurrent endometrial CA. Both had a hazard ratio of 0.28 and 0.54 respectively, favoring use of immunotherapy. Next slide, please. So the future now is prospective trials are validating the molecular guided therapy. The paradigm for molecular integrated risk assessment is now being tested prospectively in trials designed to de-escalate for appropriate or appropriately escalate adjuvant therapy based on comprehensive tumor profile. The ongoing landmark trials are the PORTEC 4A and the Rainbow program. So for high intermediate risk patient, molecular integrated risk profile is calculated, favorable, intermediate, and unfavorable after differentiating the patient. If you have favorable like a pole hypermutated, observation only is an option. Intermediate profile, you do only vaginal brachytherapy, and unfavorable pelvic radiation is one of the options. Rainbow is an umbrella of trials that assign patients to specific treatment strategies based upon their molecular subtypes. Pole mutation, de-escalation, MMR deficient is chemo plus immune checkpoint inhibitors. NSMP varies by pathology, and abnormal P53, then you have targeted therapies or systemic therapy. Next slide, please. The next frontier is subtype specific targeted therapy. Understanding the molecular drivers of each subgroup opens doors to new generation of targeted therapies beyond immunotherapy, offering potential new options for patients with recurrent and resistant disease. P53 abnormalities, copy number high, you have PARP inhibitors and HER2 targeted therapy, and NSMP, that is copy number low for P53. Then you have PIK3CA, AKT, and the mTOR pathways, which can be explored. Next slide, please. So the last slide, a new era of adjuvant therapy is now precisely tailored strategy. The management of endometrial cancer has evolved from one size fits all to highly personalized therapy, diagnosis and surgical staging. So clinical pathological assessment as well as molecular risk stratification. For pole mutated observation, for NSMP and MMR deficient early stage, vaginal brachytherapy, pelvic RT or chemoradiation. For MMR deficient, we have chemo plus immunotherapy. And for P53 abnormal, that is myoinvasive, we have chemoradiation. So with this, I'll conclude the side presentation for today, discussing adjuvant treatment in endometrial CA. Thank you.
Thank you, sir. Thank you so much for the wonderful presentation. So I thank all our panelists and the speakers for that enriching and practical discussion. As we come to the end of today's session, I would like to sincerely thank our program director, Dr. Akshay sir, and all our esteemed faculty and panelists, and every participant who has joined us and made this session interactive and meaningful. We hope today's expert insight session has helped clarify key aspects of endometrial cancer management and will positively impact your clinical practice. On behalf of IAIO, I thank you once again for your time and participation. Have a wonderful evening, and we look forward to seeing you in our upcoming sessions. Thank you all. Good night.